Welcome to Health System CIO's interview with Dr. Deepti Pandita, CMIO and VP of Clinical Informatics with UCI Health. I'm Anthony Guerra, founder and editor-in-chief. Dr. Pandita, thanks for joining me.
Thank you for having me, Anthony.
All right, very good. You want to start off by telling me a little bit about your organization and your role?
Oh, sure. Yeah. So I'm with the University of California, Irvine Health, and we are a very reputed academic health system on the West Coast located in Orange County. We are part of the University of California system in terms of academia. We are currently a 6 hospital system, soon to be 7. Um, and of the 6, we have 4 community hospitals, 1 flagship hospital in Orange, California, and then we are building a net new hospital in Irvine, which will open in December of this year. And then we are also in the process of opening a joint venture rehab hospital. So a lot of growth, a lot of hospital presence. We are, like I said, academic, so we have a lot of residency programs, a lot of fellowship programs. And additionally, we have a very large ambulatory footprint. We do about 1 million ambulatory visits a year or more. So that's sort of the landscape. We are predominantly in Orange County, California, although we do have 1 hospital that's technically in LA County.
Oh, very good. And your role? Any nuances you want to offer about it?
Yeah, so my role as the Chief Medical Information Officer is, I think of it as the translator role. So anything that touches clinical systems that is technology driven intersects with my role. So whether it be workflow, usability, assessment of systems, getting new systems, implementation, analysis, deployment, all of that. So under my role, I have a team of physician informaticists, nursing informaticists, and a training team.
Very good. All right, so you're speaking at the upcoming HIMSS conference. And your session is called Physicians Burnout, Is AI the Only Path Forward? Very interesting sort of concept there. And I assume the answer is no, and you'll get into why the answer is no. But just tell me about a little bit about the issues, themes that you're going to cover in your session, and we'll go from there.
Yeah, absolutely. So um, this is going to be a good session, mainly because it follows up on a previous webinar we did for HIMSS with the same topic, which was very well attended, and a lot of good, thoughtful questions came up in that webinar. So we thought we will take an extension of that webinar, what we heard from our attendees, and put it in a panel format. So what we're going to talk about mainly is this whole sort of conundrum of, is AI a member of your team, or is AI a sort of something that you reach out for as a shiny object, as an add-on? So any future thinking sort of system, provider, clinician would, we hope, will be looking at AI as an integral member of your team, not to say that it's going to replace current members of your team, but an add-on member to drive more efficiency, to drive more patient gains in terms of better patient experience and in terms of better outcomes, but not replacing the key tenant, which is the patient-clinician relationship. We want to preserve that while adding AI as a member of the team.
And do you think that's a danger that some people might implement these things in such a way that you disrupt that important relationship?
Absolutely. I mean, one, the entire healthcare ecosystem, whether it's today or you look back 100 years ago, everything is dependent on trust. The patients are putting trust in the healthcare system, in their clinician, in their care team. And now you bring in an unknown member of the team. Of course, people are going to question, who is this member? They have to get to know the member and trust the member before they open up to that member. So again, that trust issue is sort of the cornerstone of how these systems need to be deployed. And if you're doing it in an out of the box way that, you're just saying, oh, we're doing AI for the sake of AI because we will otherwise lose out, and not thinking about all those other factors, members of your care team who need to engage with those tools, members of your ecosystem who need to engage with the tools and build the trust in the tools, while also keeping the sacred clinician provider relationship intact. If you're not doing it in a thoughtful manner, that trust is going to get eroded.
So it sounds like what you're saying is when we're talking about IT implementing AI, bringing AI to the table, the way you do it, you have to do it in such a way that the clinicians are heavily involved, perhaps in selection, in deciding where they think AI can help in their workflows, so that they trust the tools they've been given. Does that make
Yes.
sense?
Yes. And not just the clinicians, it's also the patients. They have to trust the tools too.
So tell me about that. What I mean, it's probably on the clinician side, it's about product selection and these type of things, and that governance can come into play a lot with that. And on the patient side, it would have to do with communicating and educating about how and where exactly AI is figuring into their care, whether a clinician has been given certain suggestions or recommendations based on it, where the AI is getting that from, if any of us know. And then the fact that the clinician ultimately is the one who has endorsed the recommendation. It's not just spit out by AI and there we go. It's produced by AI. The clinician has looked at it and then accepted it, right? I mean, so there, talk about,
Absolutely.
go ahead.
I think what you're getting at is what we ought to be doing, which is being transparent to the patients in the use of AI. So whether it be, when the clinician is using an AI tool at the point of care, or whether the clinician is using an AI tool in their decision making, even, after the patient has left your office, or, the clinical interaction has ended, or responding to a patient message, as an example. I think transparency is key, alongside with that education factor you said, and building the trust that this does not mean that the clinician is not in the loop. They're always in the loop and having oversight of the AI. It's not a system running independently of the clinician oversight.
Right. Do you have any concerns of getting into a world in which a patient could opt to not have AI leveraged in any way in their care, and that might be very difficult to implement and operationalize?
Oh, absolutely. I mean, I think that is a very valid concern, because I think what most health systems are doing to deal with this whole conundrum of AI is an opt-out, opt-in process in your consent to treat document. So, when you go into a health system, you sign all those, 2 or 3 pages, which you never read, and it's all small print. And, part of it might say that, you're agreeing to participate in, systems that have leveraged AI for XYZ. Or some systems may not even go into details of where AI is leveraged. So there will be a time where AI is a key component of everything that we do. And of course, then we are going to create, if someone opts out, a disadvantage to those who opt out. I mean, where would they go? And also, I think there is also the scenario of, do we actually, as a health system, know where AI is used, you know, in all the time? And I would go out on a limb and say today, whether it be clinical teams or back office teams, we don't know 100% or knowledgeably that AI is used or not being used. So I'll give you the perfect example. If we are using an AI system to help us with, a CDI team or a billing team or a coding team, just for administrative purposes, it is a use of AI. The clinicians may not know it, the patients may not know it, and I'll tell you, some of the billers and coders may not know it either. But it gets to the heart of, if the patient is declining, how would you then acknowledge that you're not going to use that system, for billing that patient or coding their visit? So it's going to get very, very complicated very quickly in terms of, if a patient totally signs off and says, please don't use AI in my care.
Yeah, I can't imagine how that would work. So as you were talking, I was thinking that I can't think of many patients who would have a problem with AI being used in some sort of administrative billing sense, but you could see someone saying, I don't want it used in my clinical care because they're afraid that it's going to make the decision and that it's going to sort of own the decision. But if you present it in a way, especially at least with me, if I was told AI is going to be leveraged in your care and the doctor will ultimately make the decision, but AI will be a tool providing recommendations, I would certainly sign off on that. I would be very happy to sign off on that because I think it makes clinical clinicians stronger.
Yes.
I assume you agree with that.
Oh, absolutely. And this is where consent comes in. So if you educate the patient and obtain consent at the point of care, and we do this routinely for our ambient scribe use, obtain a consent, explaining why. I have had zero patients tell me that they don't want that ambient scribe, in that relationship of the patient and the provider, because they see the advantages. Now I'm looking at them rather than looking at my computer. And so it's a win-win on both sides. I think the patients are pretty well informed and educated, seeing the advantages in real time, and understand that. But you have to take that extra step of being transparent, educating them, and explaining why you're using a solution.
Well, let me ask you this. And I don't, like you said, they hand you the papers, you don't know what you're signing. You just hope for the you hope for the best. So when do we need to ask, as a health system, when do we need to ask for consent and when do we just do what we do? Um, Putting out and then if somebody says no, again, you get to the point where, well, then I don't know if we want you as a patient because this is how we provide care because we think this is what provides the best care. So you're opting for a form of care that, number one, is now not our normal workflow. It's some sort of older workflow. The clinicians will get to a point where they're not comfortable without getting that help from AI. And I think all with good reason. So you almost become undesirable as a patient if you say, I don't want any of this used in my clinical care. They said, "Well, go somewhere else."
And where will they go? Because every health system will be using AI. So I think, again, this is not only educating the patients at a health system level, this is educating the patients at a population level to say, hey, AI is going to be the future in terms of healthcare delivery. And if you are getting a consent and you're, declining, remember that that decline doesn't mean that it is just for clinical care, and your health system may not be able to even accommodate that
Right.
decline. So I think that scenario is going to come up repeatedly.
And it's very complicated. And other things that are getting complicated, and maybe those aren't the proper topics for this discussion, but the sharing of certain pieces of information, the regulatory bodies are trying to get extremely granular with allowing patients to determine what pieces of data can and will be shared in their electronic record and to change their mind on those things and have that reflected in very short time frames, an hour and things like that. So, for example, I want all these things are fine to share, but these three things I don't want to be shared. And perhaps these three things I don't want to be shared with certain physicians. And oh, by the way, I just sent you an email that I changed my mind. So things are getting very, very
It is a very gray area, and it's getting murky by the minute. because we are getting more and more use cases where AI is helpful to decrease just the administrative burden on clinicians, and beyond that, decreasing the burnout and improving the efficiency. Because we are dealing with a physician crisis as well, in terms of people leaving the workforce, or having too much after hours time or administrative burden. So these are the tools that are going to help with that. But at the same time, if the tools are going to lead to more confusion and complication on the patient side, then the tools are not serving their purpose. So I think it's a very tight balance you're walking between patient expectations and physician expectations when it comes to AI.
Let's talk a little bit more about burnout on a broad scale. I mean, there's many non-IT related things that contribute to burnout, right? That have sort of nothing to do with what we're going to talk about here. And then there's the IT related issues. Um, at a very high level, how do you parse those things in your mind? You want to help where you can with the IT stuff, but that's only going to get so far, but you need to do what you can. What do you see as the main causes of IT related burnout?
Well, certainly, the EMR was blamed for a lot of the burnout, initially. But I think, again, more recent surveys, whether it be, through class, or, even people who do their own individual surveys locally at the organization level, the EMR related burnout burden has gone down,
Yeah.
but the bigger burden now is around sort of chaos in the workspace, or lack of autonomy, or inability to control their own sort of schedules and things. So those are items that are bubbling to the top now as the cause of burnout. But still, the EMR burnout is not zero. It's still there. Most studies will tell you that it's about 10% still. So I think, again, it comes down to how you're designing your systems. Because if you are taking an out-of-the-box system and expecting everyone to use it as you're providing it, it's never going to succeed. I'm a big fan of user-centered design, and you have to, instead of plugging in IT systems into workflows, you have to assess the workflow first and then see where the IT systems fit into it. And sometimes you have to understand that they may not fit, into a workflow, and you might have to say, oh, this process can stay on paper for now because there is no good IT system to accommodate this. So again, like I said, square peg, round hole doesn't work. The workflow and the clinical use and the operational processes should drive what IT systems you implement, not the other way around.
All right, very good. You mentioned customization and how you feel that's so important. One of the areas that we see can be problematic sometimes is, so you have a health system, you have, I think you said 5 or 6 hospitals, getting one more, I think it's 6, and starting another one. Customization can cause a problem with trying to be a system, right? So you have this idea of systemness. If you're customizing in individual hospitals, creating different workflows, you want people to be able to bounce from one hospital to the other
Yeah.
and sort of feel like they're at the same health system. So is that an issue when you talk about customization? Can you over customize and risk the feelings of systemness that you also want to have?
Yeah, and that's a very valid point. So when I say customization, I mean more around customization at a service line level or at a department level. I don't think we should be customizing at a level of, like one hospital gets this set of order sets and another hospital gets this set of order sets, because ultimately it's all about quality, outcomes, good patient care, good patient experience. And there should not be that much variability around these four factors, because
Mhm.
again, a disease state, say sepsis, is a sepsis, whether you're in a community hospital, an academic hospital, it's the same disease state. And so your processes should not be that much more different in terms of treating the patient. And also, patient experience is paramount these days to health systems. You don't want to have so much customization that you impact patient experience at hospital A versus hospital B. It should be uniform. Because again, from patient flow standpoint, today for a procedure, they might be in hospital A, but tomorrow for a different procedure, they need to go to hospital B, and they should have the exact same experience. I mean, that is the key tenet of being a high reliability organization.
And you also want that experience to be similar on the physician side, right?
Absolutely.
They should
Yes,
feel the same whether they're in hospital A or hospital B. It shouldn't be, disorienting.
exactly.
Yeah. All right, very good. Let's talk a little bit about ROI. Some of these AI tools, they have what you call a soft ROI. People bring up the cost of replacing a physician if they're burned out and they leave. They try and say, okay, if we do some ambient listening, we're going to reduce pajama time, we're going to reduce burnout, we're going to retain that physician, and it costs $500,000 or $1 million to replace a physician. I don't know how these arguments play in front of CFOs, you tell me, but what are your thoughts on this idea of a soft ROI with AI? The stuff is not inexpensive. And how do you sell these things to those that are making the financial decision?
Yeah. So again, I'll tell you in my experience, the minute you say just soft ROI to a CFO, they're not going to engage with you. I mean, they need the numbers. And you're right, with the ambient tools today, we don't have the numbers, but we know where these tools are going. So you are investing in a tool that will bring returns in the future. So a lot of these ambient tools are now going to dive into suggesting decision support or CPT codes or diagnosis codes or HCC codes from a population health level. That is where the ROI will come. And I personally, as a physician, would never say that the ROI comes from seeing one extra patient, because again, from the lens of burnout, you're giving physicians back that time to take care of themselves. But there are studies out that show that with using an ambient tool, you can see one extra patient, which pays for the tool, and all of that. I think then the other revenue stream in terms of the hard ROI is a lot of physicians today use physical scribes, human scribes. A lot of them use other transcription tools, and that cost reduction from that area also is helpful in making that ROI argument. So again, yes, there is the soft ROI, but that alone does not fly in the face of a CFO in
Mhm.
making that use case. Because again, like you said, these tools are expensive.
Well, I think you make an excellent point, and it's a very interesting point. This concept of, and I don't mean to put words in your mouth. You can see if I have this right, but almost like this is not the end all state. Obviously, these tools are going to get much better, but the underlying what you're communicating, the underlying idea is don't wait. Like you need to start now, and you need to be on the ride as it picks up speed. Don't say, "Hey, I'm gonna wait till they get better a year or 2 from now because it's gonna be harder." And you tell me, is that right? That idea?
Well, again, it depends on what kind of a system you are. So, I mean, we academic health systems pride ourselves in being cutting edge, innovative, and, riding the wave as it comes on. So,
Mhm.
definitely, we are of that exact mindset that we don't want to wait. We want to be adopting new tools, early on, studying it. And we are also a big research organization. So, we study it from that research lens. For another health system that is smaller, there may be value in waiting. So I don't think you can make an argument that everyone
Okay.
should, dive right in, because
Right.
again, it depends on what kind of a system you are and what kind of use cases you're looking at.
Okay. Very good. Um, Thoughts on the future? Anything? I mean, things are moving so fast, right? They're moving incredibly fast. So, anything you're looking at that's kind of out there that you're keeping your eye on?
So, like I said, I think from the ambient space, there holds a lot of promise in terms of all these other things that it might be able to do. It is still very rudimentary in the terms of you can use it in the emergency department, perhaps, and you can use it in some ambulatory settings. It's still not a tool you can use for, proceduralists or inpatient or critical care docs or anesthesia, because, obviously there's no ambient interaction happening. So in
Mhm.
those scenarios. So these tools still leave a lot to be desired, but it's the back office stuff that is interesting. If the tools can, generate prior authorization letters, denial appeals, drop codes, place orders, that is where I think the additional value will come in. But beyond that, I think what I would like if I had a crystal ball, in terms of where AI is going, is still everything AI keeps the EMR as the third wheel in that patient provider interaction, which is
Mhm.
what we lost when EMRs came. The trust got eroded mainly because now there's a third wheel, and you're looking at the computer, or you're entering things into the computer, or you're spending more time with the computer, frankly, than you're with the patient.
Right.
I want AI to evolve to a point where that need goes away, and you're just simply going back to old school medicine where you are interacting with the patient, you're doing everything, and there is some seamless capture of everything that happens in that sacred, patient clinician relationship, and generates all the administrative needs you have, whether it be documentation, coding, billing, all of that. And
Mhm.
and we go back to just practicing medicine as it was designed to be.
Well, that's absolutely wonderful. Seems like a good spot for us to finish at. Great conversation. I'll be at HIMSS, so looking forward to your session. It was a pleasure to talk to you, and I hope I can reach out again.
Thank you, and thank you for having me on.
Have a great day, Dr. Pandita. Thank you.
Okay.